I am not paying attention to recording very well today. Okay. Um, and then adrenal corticotropin hormone, which is going to go to the adrenal gland. So we're going to talk about medications that specifically affect antidiuretic hormone, the adrenal gland hormones, the thyroid gland, and growth hormone. These other ones come into play when we're talking about the reproductive stuff. So antidiuretic hormone is a hormone that's trying to keep our fluid balance correct. So it's always good to think about what we want to happen. So if everything is normal, we would have the appropriate concentration in our bloodstream. We're not too diluted and we're not too concentrated. We don't have fluid overload and we don't have dehydration. This is what we want to have. In order to maintain that, the body releases a hormone called antidiuretic hormone. And it's supposed to affect the kidney and change the way the kidney either reabsorbs water or excretes water. So if the concentration of the blood gets too high, then we're really dehydrated. Or if we're nearing dehydration, it doesn't have to be severe dehydration, but if the blood is getting slightly more concentrated, then the kidney should release the pituitary gland should release antidiuretic hormone to tell the kidney to save water so that we can get back to the regular concentration. If the concentration is getting low, meaning we have enough fluid, we don't want to be fluid overloaded, that would be something that would tell the pituitary gland, hey, we don't need any more antidiuretic hormone. We actually can get rid of some fluid because we're fine. And then we'll get back into our normal blood concentration. And this is an example of a negative feedback system. We're trying to stay, the variable that we're talking about that we want to be in balance is the concentration of the blood. And so this is just what's involved. The posterior pituitary gland is communicating with the kidney and deciding whether or not we should diurese, which means deciding whether or not we should release more fluid or not. And so there are people that just because of a brain injury or from some other genetic injury, or maybe they have hypopituitarism in general, so they don't create any of the pituitary hormones like they're supposed to. They have a lack of antidiuretic hormone, which means that they are never going to save the urine like they're supposed to. So they will have a production of a large amount of very dilute urine, and the person is prone to having that very concentrated blood. And what usually happens is their sodium gets really high. And when people's sodium gets very high, they're at risk of seizures, which we don't want them to have. So, okay, thank you, Che. I will put that down. I know she's having Skype problems. I'm here, but I can't hear. Poor Beth. Okay, well, we continue. So, if this is my problem, then I can give somebody medication that's a synthetic replacement, essentially, for antidiuretic hormone, and that's desmopressin, specifically for the treatment of diabetes insipidus, because I want to stop them from drying out. And this can be given in many different types of ways. It can be given as IV, IM, subcutaneous. The patient could take it at home in an intranasal or by mouth format. If you're talking about intranasal, remember that the medication has to be directed towards the earlobe so that the medicine goes on the side of the nose where the mucous membrane is so that it's absorbed. Otherwise, they're not going to get the medicine. So if they feel it go down their throat, then they haven't given it properly. So, and what you'll find with all of these negative feedback type hormones and their medications is their side effects and adverse effects have to do with getting too much of the medication. So here we are, this is where we want to be, normal concentration. This person has diabetes insipidus, which means too much urine. And so they have elevated concentration, elevated sodium, and they're at risk for seizures. So I'm going to, instead of my antidiuretic hormone taking effect, I'm going to give them desmopressin because that's like the antidiuretic hormone, and this will tell the kidney to save water. Save water, please, kidney. It'll do it because the antidiuretic hormone isn't available, and that should hopefully get us back to normal concentration. Except sometimes maybe the patient took too much, or maybe the prescriber needs to alter the dosage. The problem would be, what if the patient was getting too much? Their pituitary gland isn't working, so I don't have that negative feedback to tell it to stop. That doesn't exist. So if they're getting too much, then they can become fluid overloaded. And they won't, the only way we're going to help that is by adjusting the dose of the medication. So the side effect, which could range from a side effect to an adverse effect depending on how bad this is, could be fluid overload, which means a decrease in sodium, which can lead to headaches, confusion, and also seizures. And then the patient, if they have any issue with their kidney or their heart function, we don't want them to have fluid overload because they already have that issue. So our adverse effects means that we're getting too much water. And so they would have signs of overload, they would have headache, confusion, and their blood pressure and weight would increase. So when a person is on this medication, we're going to watch their INO, we're going to watch their blood pressure, we're going to watch their weight. And these are the blood tests. We look at their sodium level because we expect it to be normal if we're giving enough medication. And we're going to check the osmolarity, which is a way to measure that concentration that we're talking about, because we want these to be normal. If they're getting the proper amount of medication, they will be normal. So that's desmopressin. Now, the next hormone we're talking about is growth hormone. So growth hormone, obviously there'll be an increase in the release of growth hormone in certain times in a person's life when they're growing a lot, such as infancy to toddlerhood, school age, when they go through a growth spurt. It does change. There is a change in level depending on meals and the availability of insulin. So it does have a link to diabetes sometimes, so you don't have to worry about that. When growth hormone is released, it tells the liver to release insulin-like growth factor, which will increase the length of bones and increase muscle mass. So the reason to give growth hormone is for people that aren't growing properly. So somebody who's pre-puberty or in puberty and they're not meeting their growth benchmarks, look like maybe they have dwarfism, or they're having a problem where they're very short stature, you could potentially give them growth hormone to increase their growth so that they're on the normal curve. You're not trying to make them super tall. This is a drug of abuse sometimes. This is when people are taking steroids. This is a steroid hormone. This is what they're taking because they're trying to build muscle mass. So obviously that's not the reason to give it. You're trying to push the person who's having growth disturbance onto the normal growth curve. And so you can give somatropin, which is synthetic growth hormone, in order to help that person. So this is a subcutaneous medication that's given several times a week for several years, depending on how long the patient's growth plates are open. So a growth plate, if this is your long bone, at the top of the bone is something called the growth plate, and that's where there's an increase in bone activity. And so this is what's susceptible to growth hormone, and that is what causes the length of the bone to increase. So during the time that the growth plate is open, I could give somebody growth hormone supplementation, which is somatropin, to assist their bone growth. Once this plate closes, then it won't work anymore. And in fact, I could cause a different problem by giving them like nodularity of their bones, because it's not going to work right. And unfortunately, sometimes when people are taking this, their own body will neutralize the synthetic growth hormone you're trying to take. So usually you can only take it for a little while. If an adolescent is on this medication, they're going to need to follow up with an endocrinologist. So they'll constantly be checking their height and weight and be sure that they are starting to meet growth benchmarks. And then they're going to have annual x-rays of their long bones, specifically their humerus and femur, to see if their growth plates have fused, because once they do, they can no longer get the medication. If a patient has closed growth plates, obviously they can't take it. Severe obesity and respiratory impairment, if you give growth hormone at the same time, you can increase the risk of respiratory distress. Same with critical illness. So you have to be careful when giving it to people in this category. So that's growth hormone. The next disorders we're going to talk about has to do with the thyroid gland. So the thyroid gland is again another example of the hypothalamus pituitary organ axis, where the hypothalamus tells the anterior pituitary this time to create a hormone called thyroid stimulating hormone that tells the thyroid gland to release thyroid hormone. So again, we're trying to keep a balance. This time we're trying to keep a normal thyroid hormone function, because the thyroid is in charge of metabolism, which is obviously very important. It does help in growth because it's linked there, and it can sensitize or help the stress response. So we always have an amount of thyroid hormone circulating in our bloodstream because it's running metabolism. And then sometimes we'll have increases of thyroid hormone related to periods of growth or stress. But there is a normal range of thyroid hormone. And if I have a normal range, then I'm feeling good. And how it should work is if the body is stimulating, so the hypothalamus stimulates the thyroid gland to produce thyroid hormone. And if the thyroid hormone is getting high, not before it gets too high, that would be a reason to decrease the amount of thyroid stimulating hormone that's being released, because I don't need any anymore. My thyroid has made enough. If the thyroid level is getting too low, then that would be a stimulus to the pituitary gland to release more thyroid stimulating hormone so that I can keep the level in the normal range. So that's what I'm trying to do, and that's how it normally works. But sometimes people will have problems with the thyroid gland itself. Either it's not making enough thyroid hormone or it's making too much, even though the body will tell it, please stop or please make more. If the thyroid gland isn't working properly, that won't help. So then they have to take medication. So the symptoms of hypothyroidism and hyperthyroidism are important to know, because then you know, is the patient, whatever problem they have, either hypothyroid or hyperthyroid, are they getting enough medication or are they getting too much medication? So here's my normal, so then I would have normal metabolism and I would have normal or assisted stress response. So then I would be fine. That means I have a normal thyroid. If my thyroid is overworking, which is usually an autoimmune disorder, I have too much circulating thyroid hormone, then I will have symptoms of hyperthyroidism, which means I will be hot, I will lose weight, I will have diarrhea, sweaty, insomnia, agitation. It might increase my blood pressure and heart rate. And at the very high extreme end is something called thyroid storm, which could potentially be deadly because it's going to cause me to have tachycardia and tachydysrhythmias. So I can take medication to try to get myself into the normal range. Some people have hypothyroidism, and so that can be easy to figure out. If hypothyroidism would be too little thyroid hormone being created, and that means I would pretty much have the opposite of hyperthyroidism. I would be cold, I would gain weight, I would have constipation. They're not sweaty, they're dry skin, dry nails. They are fatigued and have depression. And they could end up with a low blood pressure and heart rate, and that extreme end is called myxedema coma. And hopefully that won't be an issue. Then I could take medication to replace thyroid so that I would be normal. And that is what we do. We can either take medication to bind the thyroid hormone so we can be normal, or we can take thyroid hormone replacement so we can be normal. And if I take too much thyroid medication, then I might end up with symptoms of hyperthyroidism. And if I take too much of the medication that blocks thyroid function, then I might end up with hypothyroidism. So here's our hypothyroid people. We know that if you're hypothyroid, will feel cold, they'll have dry skin and nails, they'll gain weight, they'll be constipated, fatigued, depression, and at the very bad end of the spectrum, it could affect their vital signs. So they will get thyroid replacement, and the name of that medication is levothyroxine, which is a synthetic form of thyroid hormone. It can take a couple weeks for them to feel the full effect, and so you don't, test blood work right away. So their side effects are pretty easy to understand because the side effects are overtreatment. So here I am trying to increase their level of thyroid hormone by giving them levothyroxine, which is like their thyroid hormone, but then maybe I gave them too much. So their side effects, all the way side to adverse effects, depending on how many of these symptoms they feel, are the symptoms of hyperthyroidism. So on the test, the question could be, what are the side effects, or how will you know the patient isn't getting enough thyroid hormone? Well, they would still have the symptoms of hypothyroidism. How do I know they're getting too much thyroid hormone? Well, they'll then start to have symptoms of hyperthyroidism, and we want to keep that in a balance. So that one is a little easier to understand. The medication that is given for hyperthyroidism has more side effects and adverse effects than the medication for hypothyroidism. So this medication, PTU, is given several times a day, 1 tablet every 8 hours, and it stops or interferes with the synthesis of thyroid hormones. And so it could lead, just like the other side effects could be related to overtreatment. So if you give too much PTU and you're interfering with the synthesis of thyroid hormone so much so that there isn't enough, then they're going to have the symptoms they would have if they had hypothyroidism, like being cold, gaining weight, constipation, dry skin, depression, fatigue, those things. If you overtreat the patient with PTU, they can also have a decreased white blood cell count, which is leukopenia. If they have leukopenia, how will you know? What is the symptoms of leukopenia? Guys, are you with me? How do you know someone has leukopenia? Oh, okay. Right. You increase the likelihood of infection. So they might have fever, they might start to get things like upper respiratory infections more frequently, or if they get a cold, it takes longer to shake, things like that. Besides overtreatment, they also are at risk for aplastic anemia, which is really just another type of anemia. So that means they have low red blood cell count. So they have the what we talked about earlier, fatigue, pallor, weakness, and hepatotoxicity, which we've also talked about, meaning that their liver isn't functioning correctly. And this is a pregnancy category D. So that's the thyroid gland. So we're almost done, guys. We just have to get through the adrenal gland's hormones. So the adrenal gland creates a couple hormones. The adrenal gland lives on top of the kidneys, and it has a middle part, the medulla, which under stimulation can be a source of norepinephrine and epinephrine, so it's part of the sympathetic response. The outside part, the cortex, produces types of hormones. It produces glucocorticoids, mineralocorticoids, and androgens. So the glucocorticoid is cortisol. The mineralocorticoid is aldosterone, both of which we've talked about before. And androgens is the body's source, one of the body's sources of testosterone. This is the main source of testosterone for women, because the main source of testosterone for men is the testes. So we all have estrogen and testosterone inside, men and women, so that can change how we present what we typically think of as gender signs, which of course is a social construct. I'd just like to throw that in there. So anyway, if the adrenal gland is functioning properly, then when we need it to work, which is always, but sometimes we need a little extra in times of stress or the need to conserve fluid, then when it gets stimulus from the anterior pituitary gland, we will release cortisol, aldosterone, and androgens. So we'll talk about androgens, so I'm just going to cross it out for now, when we talk about the reproduction unit, because we can manipulate or change the amount of testosterone. So we're not going to worry about androgens right now. We should know what aldosterone does, because that was part of the renin-angiotensin-aldosterone system. When the body does all the conversions from angiotensinogen to angiotensin 1 to angiotensin 2, angiotensin 2 is another way to stimulate the adrenal gland to create aldosterone, which saves water by saving sodium and gets rid of potassium. And that's why if we block that system like we do for those ACE inhibitors and angiotensin receptor blockers, we get rid of water and keep potassium. So this is what we want. When we're low on water, our blood pressure is low, and in times of stress, we want to save water so that we maintain our blood pressure. The other thing is the stress hormone cortisol, which is supposed to help the sympathetic nervous system work better to keep our blood pressure and heart rate up in times of stress. It suppresses the infection and inflammatory system on purpose, because in times of stress, we don't want to waste energy. And it helps to break down muscle and fat as a source of sugar, which in times of stress we would need. So if we increase This is why, of course, when we take too much prednisone, which is the synthetic cortisol that we've talked about already, we can have trouble with our vital signs. We can increase the amount of water that we save. We can have decreased infection and immune response, and we can increase our blood sugar. So the need that we have for cortisol and aldosterone changes depending on what's going on. We always need a little bit, so we wouldn't be awake or have maintained much of our blood pressure anyways, but in times of stress, we're definitely going to need more. So there are people that do not make enough of these hormones. And this is what we're talking about, in which we would give a medication to supplement that. So the main issue that somebody who is not secreting enough cortisol and aldosterone is that they will have, here is the normal. So we have normal blood pressure and we are awake. That's what we want. If we have too little of the both cortisol and aldosterone, then we will definitely have a decreased blood pressure and we will have fatigue. And that is the biggest risk of someone who has what's called Addison's disease. If we have too much, so too much cortisol and aldosterone, we will be more so have like insomnia, anxiety, and our blood pressure will be high, plus all the other things we know that happens, especially with too much prednisone, which is synthetic cortisol. We have hyperglycemia, we suppress inflammation and the immune response, so we're at risk of infection. We're increasing fluid retention. We are increasing blood sugar, some of those other things we're talking about, because that's Cushing's. So we're specifically talking about in terms of medication, how we can help somebody who has Addison's disease. And people with Addison's disease, who have this low blood pressure and fatigue, need replacement of hormones to keep them in the right range. So we can give them a different form of synthetic cortisol, which is hydrocortisone. And this is used to treat adrenal insufficiency or Addison's disease. So we specifically want, this is a lower dose than we would use for autoimmune diseases or anti-inflammatory. So, and it's generally a different form. We don't want to stop this suddenly or they'll go into withdrawal. This is something that we want the if they have too much of this, just like for the other ones, if we gave somebody, because they're not making enough, we decide to give them hydrocortisone because we want them to be in the normal range. If we give too much, then we're going to end up in the Cushing side with the people that have hypertension and hyperglycemia, and they have that fat redistribution, so they have, because the muscles are breaking down in the extremities, they have the moon face and buffalo hump and those kinds of things. So usually people that are on this medication have to be on it forever. This is the other risk because hydrocortisone acts like prednisone, which is also a COX-1, COX-2 inhibitor. That's how prednisone decreases inflammation. And we know COX-2 is the pro-inflammatory production of prostaglandin. So if we decrease that, then we bring inflammation down, which is fine. But the COX-1 is cytoprotective. So that means we're trying to increase kidney perfusion to protect the kidneys, and we're going to try to protect the stomach by decreasing acid production. So if I give the patient too much cortisol, they may actually harm their stomach, which is the short story to that. we're on this, we would have to gradually withdraw to allow for normal function. But again, someone who is on this medicine because of Addison's disease will be on it forever. Additionally, people with Addison's disease will also have a decrease in aldosterone, which is fluid. Remember, that's the keeping fluid and sodium and getting rid of potassium. So with hydrocortisone, I can take fludrocortisone, and it's helpful. I always think fluids. That's what I'm trying to do, is increase keeping the fluids. So I would take this every day or 3 times a week. And again, just like the other medications, I'm taking this fludrocortisone, which is which is supposed to act like aldosterone, saving water and sodium and getting rid of potassium. If I take too much, then I will end up with hypertension and too much sodium and too little potassium. So that is our hormone stuff. It's a lot of information, I know. Is there any questions right now about what we've talked about today, or about what's coming up for the remainder of the semester? Brain fried. I know. This class is, I would imagine at the end of this class, I feel that way too, but I'm sure you guys do, that by the end of this class, you're just exhausted because it's so much information. Yes. Was this you? Did you have your with Bed Surge Better? I know I got this. I don't know. I think I took too long on one of our subjects, so kind of threw the schedule off. Yeah, because I know that you guys did diabetes already, so sorry about that. But then this should be easy for you guys because this hopefully is familiar. Nope. Well, okay, I'm glad. I like that. Very honest. No. Okay, so it is, some people, I mean, it's, you just have to, what I caution people is to think about what you want. This is what I want. I want this to be a normal level, and these particular things, either my blood concentration is correct, or my metabolism is correct, or my blood pressure is normal. And if I have too much or too little, what that would look like. And then if I'm going to give medication to correct it, then I should be going back to normal. So that's what I find. These test questions sometimes you need to just take a second and think about what is actually going on. If this patient has this syndrome and I am giving them this medication, then I expect them to go back to normal. But it does take some time. Easy for me to say because I've been a nurse for over 20 years. So, because I'm old. So don't forget, next class, ATI for endocrinology should be uploaded. And we're going to take a quiz on those 6 hypoglycemics, those oral hypoglycemics. And I will try to get this up faster than I did the last one. I think I just forgot, actually. I was going to make up an excuse, but I don't have one. So I'll try to take care of that today. All right. So have a good week, guys. And thanks. Have a good week, and then I will see you next week. We're almost done. Yay! You are welcome. So let me